Ladies and gentlemen, good morning, good afternoon, good evening. Thanks to Orbis for inviting me to give you this talk about using OCT as an approach to diagnose glaucomatous and other optic neuropathies. My name is Christian Mardin and I work as an ophthalmologist in the University Hospital of Erlangen. My outline today is just to introduce you the OCT toolbox and the role of the retinal ganglion cell layer measurement. We'll talk about the appearance of glaucomas, other optic neuropathies, and in the end, we will discuss a little bit about this swelling. When we have to deal with patients with optic neuropathies, we will encounter these three archetypes: glaucomatous optic disc atrophy, a simple optic disc atrophy, and a swollen disc. But still, by diagnosing these patients, we know that there are many shades of gray in between them. And sometimes it's difficult to say by the appearance what's the reason behind it. And you need for that many examinations. And we will discuss today this topic by using our Spectralis OCT toolbox. With the optical coherence tomography nowadays using the Spectralis, we are able to measure the width of the neural rim and compared to a normative database. We are able to measure retinal nerve fiber layer thickness around the optic disc and compare it to a normative database. If the patients are in a normal range, then they are flagged out in green in this Garway-Heath diagram. If they are yellow, they are borderline, 95% percentile, and if they are pathologic beyond the 99% percentile, they are flagged out in red. The same we can do for retinal nerve, for the retinal ganglion cell layer thickness in the macula. With a cube scan of the macula, we are able to segment the thickness of the ganglion cell layer and also compare it to a normative database with this deviation maps. In future, we will apply OCT angiography also to the macula and peri-optic area in order to define where the damage is and what kind of damage do we encounter. Let's talk a little bit more about the deviation maps of the macula. This is quite an interesting tool, especially in the differential diagnosis for optic neuropathies. And the thickness of the ganglion cells of the retinal nerve fiber layer and in the plexiform layer is compared again with a normative database. And again, in green, normative values, in yellow, suspect, and in 99 percentile in red for pathologically thinned layers. And again, in the center, we get readings in this wheel diagram with the mean thickness of the ganglion cells in the center. But we are able to exploit the whole image to see where topographically we have a problem, for example, here with the ganglion cells. When we think about ganglion cells, we have to think how the axons go further. And this is quite an interesting story when we discuss optic neuropathies. So we encounter mostly two types of ganglion cells. In the center, the so-called P cells, the midget cells. And these cells project to the lateral geniculate nucleus in the parvocellular layer. They are centered to the center of our optic disc. And a little bit more to the periphery of our macula, we find the so-called M cells, the parasol cells, and they project to the magnocellular layers of our lateral geniculate nucleus. And this is quite important to keep in mind if we encounter different neurological diseases. When we look more in detail in the center and do an overlay with our deviation maps of the macula, we are able to see pronounced thinning of the ganglion cells and are able, by correlating it with the region of atrophy, to say which kind of ganglion cells might be damaged and get a hint towards the underlying disease. For example, we know from the literature, from this very nice paper of Lamorgia, that, for example, in Parkinson's disease, we find an atrophy of the central P cells, more likely than in Alzheimer's disease, where more likely we encounter a loss of the M cells, and therefore the region of ganglion cell atrophy may be different between those two degenerative diseases in neurology. But to begin with, we encounter first our glaucoma patient. The glaucomatous optic atrophy is the optic atrophy most often seen in our everyday life. And it's quite easy to diagnose because during the disease, we have an enlargement of our optic cup. We have a loss of rim, and the rim keeps the same color as the healthy rim, in contrast to the simple optic atrophy. The loss of rim is flanked with a loss of retinal nerve fiber layer thickness. In this case, is the typical place of the first loss of axons and rim. That's the temporally inferior sector of our optic disc. And in this case, we see a 52 years old female patient with a thin rim, all flagged in red, and we see the pronounced thinning of the nerve fiber layer with a red sector here, and in the B scan we are able to appreciate the thin nerve fiber layer, which is very important to look at because the B scan has a lot of information for us we will discuss later, and of course we always have to check for segmentation errors before we trust this mathematic evaluation. When we look in the ganglion cell layer of this glaucoma patient, we realize that the ganglion cells are thinned in the area where the axons have the offspring, and we see the pronunciation of the inferior hemifield. The superior hemifield starts to have a problem, but the inferior hemifield is most damaged, and in this wheel chart, we see that the ganglion cells are thinned in the area beyond the 99% percentile. So this is very exact information we don't get by ophthalmoscopy, and then it's easy to correlate the visual field of our patient who has a defect in the upper hemifield, very close to the center, nicely correlating to the ganglion cell loss in the inferior sector. When we do an overlay with OCT angiography, for example, we easily appreciate the loss of vessel density in the area where the inner layers of the retinal structure and retinal thickness is lost. It's nerve fiber layer and ganglion cell layer. When the glaucoma continues and progresses, and when we have a nearly total optic atrophy, then we have ganglion cell loss, a broad ganglion cell loss in the area in the superior and inferior hemifield. There's a very nice paper in IOVS from New York from 23 showing how the ganglion cell layer loss in glaucomas slowly progresses. Typically, we have to look at the vulnerability zones he defines in the temporal inferior and temporal superior sector, where we see the first loss of axons, and the ganglion cells are then thinned a little bit more to the periphery in the upper hemifield and the lower hemifield. And then with progressive disease, these zones are left. Axon loss slowly moves towards the papillomacular bundle, and also the loss of ganglion cells then start to move to the center, as it is nicely imaged here in his graph from his paper. And this is a typical change, which is rather typical for glaucoma disease, and gives us an idea in the differential diagnosis from other optic neuropathies. The reason may be that the pores of our lamina fibrosa in the upper and lower part of the lamina fibrosa have the largest holes, and perhaps the mechanical vulnerability is larger than on the temporal and nasal side. We have to remember that in glaucomas, the papillomacular bundle is the last structure to be thinned and lost. But there are also qualitative changes we find in our B scans or infrared images in the spectralis. We see nicely the loss of nerve fiber layer as a darker area in contrast to the healthy nerve fibers on the infrared picture. We encounter also a splitting of the nerve fiber layer in interaction with the vitreous body and the limiting membrane. You have a Swiss cheese-like change of disease, retinal nerve fiber layer, which can cause an artificial thickening. We have, of course, the thinning of the nerve fiber layer, and when you look a little bit closer, you will realize that also the reflectivity is lost in these diseased areas. When you have a progressed disease in the lamina fibrosa, you will encounter this acquired pits, defects in the lamina fibrosa. And interestingly, when you look into the internuclear layer of the macula, you will realize the cystoid changes in the area where the ganglion cells above with the red arrow are a little bit thinned. This is a quite interesting change, which is not typical for glaucoma, but is also found in other diseases, as you can see from this nice article from Benjamin Wolf. In all kinds of different optic neuropathies with cystoid changes may appear. We see them quite often in patients with multiple sclerosis. So this leads us to the other optic neuropathies we can see in our everyday clinical work. So again, an example, and that's something to make you a little bit think about the case. This is a 70-year-old man who was under topical glaucoma therapy and was sent to us to get glaucoma surgery. This was the appearance of the optic disc. This was the visual field of our patient, and I will share with you the OCT examination. You see the thinning of the rim, and you see here the thinning of the ganglion cells in the macular area and the changes in the retinal thickness. So I would like to ask you, which statement is incorrect? So incorrect. First, rim loss superiorly found. Second, visual field defect inferiorly, GCL thinning superiorly, or this is a typical glaucoma. So which answer would be the incorrect answer? I would like to cooperate and give me your opinion. And yes, the incorrect answer, the majority is right again. It's not a typical glaucoma. That's correct. When you have a close look at the optic disc, the palea of the rim is not typical for glaucoma. That's the first thing. So let's continue. And we see again the palea of the superior optic disc with the visual field loss inferiorly respecting the horizontal line. We see the fluorescein angiography we immediately did when the patient was taken to the ward, and we see the darkness of fluorescein uptake in the upper part of the optic disc. Reminds us of the Sinhaller circle of the optic disc, anastomosis of the vessels, and this fits nicely to a patient having an anterior ischemic optic neuropathy and not glaucoma. So the majority was right again. We continue with our next case. When you look at the visual fields, everybody of you will realize this is not quite normal. When you look at the optic disc of our patient, just a moment, I get my cursor again. Yes, you will see a very faint paleness, not looking like glaucoma, of course, in the visual field, with the homonymous defect to the upper left hemifield. Doesn't look like glaucoma at all. This is a patient who had a resection of the temporal glioblastoma, and this is the visual field, of course, and this is the rim and the nerve fiber layer thickness of our patient, not flagging too much pathology in the beginning. You see the nerve fiber layer is quite thick. That's nice. And when you look at the minimum rim width, optic nerve head, the measurements are in the normative range. And when we look at the nerve fiber layer in the course of the disease, we see that the patient slowly changes. On the right-hand side, you see the change of the visual fields under a follow-up examination. The follow-up examination is about 3 years. And here you have the ganglion cells in the beginning on the left-hand side. So you see a thinning of the nasal ganglion cells. Look at the vertical orientation. On the right-hand side, on the right eye, the temporal ganglion cells doesn't show too much. And then we continue in the time, and you see that here the nasal defect becomes a little bit larger. And then the temporal defect also appears in the course of the follow-up examination. And you will realize that the defect grows larger in the following up, although the tumor is stopped, doesn't grow. And you also see that the visual field, now the horizontal midline is crossed and the visual field defects grow to the lower hemifield as the ganglion cells are showing to be lost in the upper hemifield also. So it's a very nice correlation, ganglion cells topography to visual field structure and function. So what we encounter here has been already described a long time ago by Hoyt in this 72 publication, observing red-free illumination of the fundus of young patients. And he encountered also a defect in the right temporal optic tract. And here you lose the nasal fibers on the contralateral eye and the temporal fibers of the ipsilateral eye. And this reminds on the contralateral eye of a bow tie, and therefore it is called a bow tie atrophy. So this can beautifully be imaged now with OCT and more easily than just looking at red-free photographs. So the transgeniculate atrophy was something which was, to be said, impossible 30 years ago when I started my training and in grown-ups. But now we see with OCT that it happens, and there's a nice overview about this topic in neurology from Mühlemann, and he gives us a time perspective when to expect the first changes in the macula. He tells us that in the postgeniculate lesions, you need to have to wait 5 to 6 months to see the first thinning of the ganglion cells. And if the change or the damage is more anterior, you have to wait 4 to 6 weeks to see something in the macula or the optic disc. We know the old rule that the palea of the optic disc happens to be seen after 6 weeks, the temporal palea. So when you look into neuropathies of the optic nerve, you have to think of compressive lesions, of ischemic lesions, inflammatory and neurodegenerative loss of axons. So we distinguish between so-called ascendant and descendant atrophy. And the descendant atrophy takes a little bit more time than, of course, the ascendant atrophy to be seen at optic disc, on optic disc photographs or in our OCT examination. This very young patient, 35 years old, has a chronic relapsing inflammatory optic neuropathy, also called CREON. And this patient experiences a rapid loss of vision and visual acuity. These are the visual fields, right on the right-hand side, left on the left-hand side, and these are the optic disc photographs. You will appreciate a temporal palea of the optic disc with a normal cupping. And when we look in our OCT examination, strikingly, we see a thinning of the retinal nerve fibers layer in the papillar macular bundle, showing us that it has something to be neurologic and it's not glaucoma typically. And when we look at the deviation maps, we see a circular thinning of the ganglion cells in the upper and lower hemifield, showing this red circle. This is a patient who has an optic disc damage from another disease. It's a toxic disease due to alcohol abuse. And this patient shows us a slight thinning and thinning of the neural rim in form of a simple atrophy. Here, we don't encounter enlargement of the cupping, but we encounter a thinning or flattening of the optic disc rim due to atrophy of the axons. The glial cells seem to be preserved. And when you look at the nerve fiber layer thickness, you see a thinning of the nerve fiber layer in the borderline area temporally. The rest of the retinal nerve fiber layer is nicely preserved. When we look at the ganglion cells layer thickness in the deviation maps, we see again this red ring of ganglion cell loss on both eyes, indicating something neurologic going on. And this is the thickness of the retinal nerve fiber layer again. And you will realize that the pattern is quite different from our ganglion cells with the red circle. When we look in the inner plexiform layer, you will also encounter the circle-like atrophy of the ganglion cells in the red, flagging out thinning of the ganglion cells beyond the 99% percentile. So I like to call this a red circle sign. And when you encounter this red circle sign, you have to think of some neurological disease not related to glaucoma. So again, a patient who we had to do vitrectomy with silicone oil for retinal detachment, and a rather young patient, we had to remove the oil. The patient experienced vision loss, and first we thought we might have optic atrophy, but here optic atrophy was not present in the patient, both in the rim and the nerve fiber layer. But when we looked in the ganglion cell layer, we see a thinning, circular thinning of the ganglion cells. And this is unfortunately happening when you use a silicone oil taponnade, and you may encounter, and even after removal of the silicone oil, this patient does not gain vision, which is very unhappy. This patient reports a reduced vision since 2 weeks after heavy lifting on the right-hand eye, and the left-hand eye, unfortunately, is amblyopia. So we did a visual field. We got this visual field. You will appreciate the right-hand side, the left-hand side on the left. And this patient shows a typical multiple sclerosis pattern. Atrophy of the rim a little bit on the temporal side, temporal inferiorly, thinning of the nerve fiber layer pronounced temporally on both sides. And when we look a little bit closer in the papillomaculary bundle, you will realize that on the right-hand side, we have a problem. On the left-hand side, a little bit less with the central bundle, papillomaculary bundle. So, okay, you would say multiple sclerosis, it's fine, it's the same. So my question for you would be these four. Which statement is correct? Optic disc shows no sign of atrophy. Glaucomatous visual field loss typically, bilateral red circle sign is positive, and all findings support a suspect multiple sclerosis. So you should think of multiple sclerosis. So which of these four options is the most correct one? Please go to the ballot. I'm curious what you would say after this 20 minutes of the first lecture time. So which answer is correct? It's a bilateral red circle sign. It's correct. And all findings support the suspect multiple sclerosis. Yes, we thought the same. But of course, when you do the workup, you don't stop with our OCT toolbox. Of course, you do an MRI and CT scan of the brain. And interestingly enough, we found that the patient had a craniopharyngioma, so a compressive disease, mimicking the red circle sign of a multiple sclerosis patient. Therefore, this is the lesson we have learned from this patient. Never fully trust the Optic OCT and all our toolbox, but of course you have to continue the checkup of the patient by the book, and MRI scan, this case revealed, of course, this change of this compressive craniopharyngioma. And critically, we go back to the visual fields. What do we see? We overlook the vertical orientation of the defect. So this patient has a homonymous defect to the left-hand side, which should has us think of something in the in the crossing of our both nerve fibers and of the both optic nerve heads in the center, and hypophysis would be the first to think of, but all other tumors, and in this case it was a craniopharyngioma. And of course the neurosurgeons had to deal with the patient. So when you want to do a rough differential diagnosis between glaucomatous and simple optic atrophy due to other neurological diseases, when you compare the nerve fiber layer with the rim width with the ganglion cell layer thickness, in normals all should be normal, of course. This can sometimes be tricky with the rim width due to anatomic changes and variability of the optic nerve head. But then when we go to glaucoma, there has to be some pathology in all three measurements, nerve fiber layer, rim, and ganglion cells. But in the neurologic patients, when you appear with an optic disc failure, first in the temporal and later the whole rim becomes atrophic and pale, then we most often encounter with a pronounced loss of ganglion cell layer thickness in the macula with the OCT, followed by a nerve fiber layer thickness, most often in the temporal side, and most often rim, unlike the glaucoma, is not much change. As I said, the rim becomes pale, the rim gets a little bit flattened, but the cupping does not enlarge as it does in glaucoma. So by the comparison of all three measurements, you may get a hint with which kind of disease you have to do, especially in patients you would call a normal Teichgen glaucoma patient. When we look at the thinning pattern of the ganglion cells, we can differentiate roughly 4 types. So one type would be in glaucoma, found in glaucomas or Alzheimer's disease. That's the arcuate temporal orientation in the upper or lower hemifield in glaucomas of ganglion cell loss, resembling a nautilus. And when you have chiasmal problems or retrochiasmal problems, you encounter a vertical orientation of visual field defects as you encounter a vertical orientation of the ganglion cell layer thinning, resembling a half moon. When you have an anterior ischemic optic neuropathy, you may encounter a loss of perfusion in the upper or lower part of the optic disc, leading to a thinning of the ganglion cells in the upper or lower hemifield, like resembling a sunset. And the fourth change is the red circle sign you may see in patients with multiple sclerosis, Leber's optic neuropathy, Parkinson's disease, and other diseases. I have shown you also toxic diseases showing this typical circle-shaped atrophy of the ganglion cells, and beyond the 99th percentile, flagged out in red in the deviation maps, and therefore we call it a red circle sign. So the last chapter we would like to discuss together is disc swelling. Disc swelling is not as easy to diagnose as one would think. Of course, we have to first think in a disc swelling, do we have a loss of vision or we do not have a loss of vision? Do we have a loss of visual field or not a loss of visual field? As you see, you can't use ophthalmoscopy and OCT only on all these changes. You always have to use the visual field, which is very helpful, and all the other diagnostic tools you may have, going to MRI and all the neighbors, neurologists, otorhinolaryngology, you have to ask and do a cooperation with them in order to deal with the patient. But the first idea you get from this kind of examination. Let's look at the first patient with a so-called swollen disc. This patient is rather easy because it's an elder patient and you easily appreciate with fundoscopy already the Drusen. But the workflow in many places is that you first get the OCT, you have not dilated the pupil yet, you don't get a picture of the optic disc, and then you have to get an interpretation already of the OCT, and then this could be sometimes misleading. When you look at the optic disc, you appreciate the drusen. Of course, you can do an echography and you see the highly reflective area in the B scan. When you look at these optic discs with your OCT, with rim width measurements, for example, the rim is ridiculously thickened beyond the normal range, and you will encounter in elder patients, not in young patients where drusen are deeper, you will encounter the superficial drusen with dark center and a little hyper-reflective surface. Then the diagnosis is rather easy. When you look at the retinal nerve fiber layer, you may encounter a thinned nerve fiber layer in these patients in complicated drusen, accompanied with visual field defects. And this is in contrast with the rim, which is supernormal, and the nerve fiber layer very progressively thinned. And most often, when we look at the BMO area opening reading in the areas are much smaller than normals. The normal BMO area would be around 0.8 square millimeter, and this patient had 0.7 square millimeter because drusen discs are most often small discs. This patient had a rather diffuse loss of ganglion cells, not respecting the midline horizontally or vertically in both eyes, and it is a crazy pattern of atrophy, and therefore the visual field defects are also have a very crazy pattern, and this pattern doesn't fit to all the cases we have discussed up to now, respecting the horizontal or vertical line. And when you do an overlay with the hood graphic, you flip your ganglion cell layer image, then you get a nice correlation upside down with the visual field defects. This is a young woman we saw 6 weeks ago with an idiopathic cranial hypertension, 45 centimeter water was the opening pressure of the cerebrospinal fluid. Vision was full, 90-degree visual field was fine, and in the 30-degree visual field with the octopus, you realize the enlargement of the blind spot, a typical finding for papilledema, where the visual field is still in the beginning good and the visual acuity is normal. You see a flattening of the hypothesis. And when we look in our OCT scans, I show you OCT scans through the macula horizontally, you will appreciate this pattern lines, this wrinkling on the flank of our disc edema. This does not happen in very small discs, in hyperopic discs, or you would not encounter this sign in patients with drusen. But if the disc is really swollen to inflammation, to hypertension, or ischemia, when you encounter this pattern lines, you see the small wrinkles of the flank of our optic disc. Of course, you can perform then a star scan and a volume scan of the disc. You don't do this scan in order to do the diagnosis. You see it by your eyes, but for the follow-up examination, it's rather useful to see whether the patient responds to therapy by flattening of the disc, by reduction of the optic disc edema or not. Of course, you take the echography in order to measure, of course, and demonstrate the disc swelling. But nowadays, in the course of the disease, OCT has a much higher resolution than echography. For example, this is a patient encountering a change of the volume of the optic disc, and this change in this volume scan can easily be shown by the volume measurements and by the topography of our optic disc. And here the OCT is very helpful, also showing us very small steps of change. When you look at the star scan, you will realize in this graphic with event-based how under therapy this flattening of the optic disc takes place. And we always combine this with a circle scan of the nerve fiber layer, because sometimes you encounter a loss of nerve fiber layer thickness. And here beautifully in this event-based analysis, you see the topographically image change of the retinal nerve fiber layer in the course of the therapy of this patient, in this case with acetazolamide and lumbar puncture. When you have a disc swelling and a beginning optic atrophy, then something is wrong, especially when you look at the optic disc and you have this kind of Friesen sign, this enlarged capillaries at the optic disc. This must let you think of something which is growing in the orbit or the apex of the orbit. And in this case, this patient suffered from a meningioma. You see the swollen optic disc, but you also realize the palea here. And in the course of this tumor, the optic disc atrophy became complete. Swelling always goes down, and the optic disc becomes pale. And this change can easily be visualized with OCT in the course and can be measured at any point you want to, or you get a volume if you do an optic disc volume measurement. So if you have a compressive descending atrophy optic disc after papilledema, it may end up like this with visual field affairs and defects of the retinal nerve fiber layer. This, in contrast, is the healthy eye with a normal measurement of the nerve fiber layer in the course of the disease. So in unilateral disc edema with vision loss, you have always do an imaging of the brain and orbit to rule out the tumor. This patient, as we have shown, had an optic nerve meningioma. And you have here in the T2 weight MRI scan the contrast enhancement of the optic disc in the anterior part, and then the atrophy in the part of the tumor. And we are able to see the inner part on the optic disc with OCT and measure everything. So this is a patient, 68 years old, acute vision loss left, and suspect optic anterior ischemic optic neuropathy. He had already such an event on the right-hand side and came now acutely with a swollen optic disc and visual field loss on his former better eye here. And when we look again in our rim measurement, the rim looks quite nice on the right-hand side. On the left-hand side, with the acute swelling, we see an enlarged reading for rim width and also an enlarged reading for the thickness of the retinal nerve fiber layer. On the older right side, we see already the optic atrophy pronounced in the superior hemifield, corresponding to the paleness of the disc. And here again, the ganglion cells in the superior part are lost. And here already we have a beginning thinning of the ganglion cells, although the nerve fiber layer is already still thickened by the edema. But if you encounter this image, you have always to think of a brain tumor. It can, of course, always be as the second eye with an anterior ischemic optic neuropathy, but it can be also a Foster-Kennedy syndrome with a large tumor of the brain, leading to an atrophy of the first disc and later on to a disc swelling due to elevated cerebrospinal fluid pressure. And then you have a similar picture as in our ischemic optic neuropathy patients, but the visual fields may then be different. So myelinated nerve fibers, they look dangerous, but they are harmless, but they cause a thickening of our nerve fiber layer too, and are a pseudoedema. Leber's optic neuropathy starts with a swelling of the disc, leading to a fast failure of the disc and fast vision loss. And as in this young patient, this patient encountered a rapid vision loss. We first thought about a multiple sclerosis or prion inflammatory change, but the analysis of the mitochondrial DNA revealed Leber's optic neuropathy. And here you encounter a rapid loss of nerve fiber layer thickness with your OCT over time. And then you have to think about Leber's disease or some very aggressive inflammatory disease like prion. At the end, the patient lost a lot of nerve fibers and visual field. So you can differentiate with autosomal dominant optic neuropathy not being as aggressive in nerve fiber layer loss as Leber's optic neuropathy, as it has been shown by the publication of Azanat. So when you have disc swelling, you have a thickening of the rim, you have a thickening of the nerve fiber, you have to think of a papillitis, disc edema, anterior ischemic optic neuropathy, or myelinated nerve fiber layer. Here you have to have a look at the function, visual field, and visual acuity. If the rim is thickened and the nerve fiber layer is thinned, then you may have complicated Drusen. If the ganglion cell thickness may help you a lot, in this case for differential diagnosis, visual acuity, visual field, and of course, echography and MRI. OCT is never standing alone, as helpful as it might be in this talk. So to close my talk, I have the last question for you. I am demonstrating you a very young patient, 18-year-old girl, 98 kilograms, rather 185 centimeters height, full vision, headache for 2 weeks, and was referred to a neurologist for a checkup and to rule out papilledema. Unfortunately, the discs were rather swollen, and I have the question for you now. This is bilateral papilledema. Physiognomy could be typical normal nerve fiber layer in OCT, idiopathic cranial hypertension, and a normal visual field. Which statement is the most correct in this case? So this patient has all the features of idiopathic cranial hypertension, and normal visual field is also right. The wrong thing is that the patient doesn't have a bilateral papilledema, although it looks like that. When we got the patient to work up, we realized that the patient was hyperopic, she was undercorrected, she was learning hard for 2 weeks, reading a lot of books, and got headache because she was latent hyperopic with a microdisc. So this is the differential diagnosis for disc edema and could be misleading, as in this patient, everything was done. MRI, spinal fluid tap, and then she saw the ophthalmologist. Unfortunately, this was the wrong row. And also in our B scan, we didn't see a flying bat sign, so everything was normal. So with this last minute, I would like to say thank you for your attention. I have shown how you can apply OCT examination, the toolbox, on your optic nerve head diseases. But I have also shown you that OCT is not everything. It just gives you a hint in addition to your ophthalmoscopy. And in the end, you have to decide which other examinations you have to do. And I hope you learned a little bit from that talk, and I'm very looking forward to your questions. Thank you very much. So I have opened now the question and answers row, and I would like to start answering the questions. How we predict visual field pattern, flicked by macula, ganglion cell OCT? Yes, that's the way you can do it. And then you can point-wise correlate your visual field defects with the ganglion cell layer loss. And astonishingly, this works quite good. Another question was, many now coming in. What is the isn't rule, or the isn't rule saying in glaucomas that the inferior part of the rim is the thickest, followed by the superior part, followed by the nasal, and the thinnest part should be in a normal disc, the temporal side. So if the inferior rim becomes thinner than the superior part, then you have a beginning glaucoma, most often without visual fields. That's the work of Jost Jonas and one of his major achievements. Another question is it normal to have a linear or vertical CDR 0? Yes, in very small disc, you don't have a cupping, so it's 0. And if these discs start with glaucoma, they have a beginning cupping, but this can already be pathologic. Which study has the most sensitivity in early glaucoma? Campimetry or OCT? Well, I'm a little bit more morphologically oriented, and I trust it's always the nerve fiber layer measurement, and then followed by visual field examinations or campimetry by sensory tests. Is it normal to have no optic disc edema, no vision loss, absolutely nothing, but a CDR 0 in a 30-year-old female? Yes, I think the last patient answered this question. In hyperopics, you may encounter exactly this situation. And if the patient, as in our case, had an undercorrection and reads a lot, gets headaches, and this very much resembles papilledema due to elevated intracranial pressure, and then you get a problem. Will ETOH excess present the same on OCT as vitamin deficiency of the optic neuropathy? This is an interesting question, and I left out exactly this case because in vitamin A deficiency, you have a normal ganglion cell layer thickness. You have the problem in the periphery, in the layer of the photoreceptors and the outer nuclear layer. The whole retina thins, but the ganglion cells still are more normal than the outer areas, and so you can distinguish these patients from other optic neuropathies, and by supplementation of vitamin A, the thickness becomes normal again, the photoreceptors form up, and the patients gain their vision again if it's not been a very long time of a deficiency. What is the explanation? There is ganglion cell loss, but normal retinal nerve fiber layer, for example, in red circle disease. So before I would think of something pathologic, I would always check my segmentation, whether the segmentation is correct. And I'm unhappy to say that in very shallow foveas, you may encounter a red circle sign as a false positive. So before thinking of something neurologic where the red circle sign appears before nerve fiber layer measurement lost, I would always check the B scan. The role of intraocular pressure in optic nerve head disease. I think the question hints towards other neuropathies than glaucoma. In glaucoma, we know we have to lower the IOP. In other optic neuropathies, there's no evidence for that, whether lowering the optic IOP has a good effect on the progression of the disease. What we do, but that's off-label, what we do in patients with complicated disc Drusen, where you seem to do nothing, we give alpha agonists in order to preserve a little bit the nerve fiber layer and lower the pressure in order to help the patient, but there's no evidence for that at all. Yes, the abbreviation for BMO MRW is Bruch's membrane opening base minimum rim width. That's a specialty of our spectralis, and Claude Bourgogne and Joan from Halifax, they coined this name. It's rather complicated, but the abbreviation stands for Bruch's membrane opening base. This is diagnosed by the device, the opening of the Bruch's membrane, and then you take the shortest distance to the limited membrane, then you have the reading and the measurement of the rim, and therefore it's followed by MRW. It's rather difficult to pronounce every time I'm having my talks. How do you investigate a normal tension glaucoma suspect? Well, we do the normal workup you would do for glaucoma, apply our OCT toolbox not to encounter a red circle sign. And what we always do is CT or MRI scan of the brain in order to rule out a midline tumor. It has been shown in some publications that you may encounter in 5% a midline tumor. And therefore, in these patients, we always perform this kind of imaging. So next question is, those ganglion cell thickness reduced only in glaucoma? No, we have seen that the ganglion cell thickness is reduced in all kinds of optic neuropathies. Just the pattern looks different, as I've shown in one of my slides. What if we don't have perimetry? Can we rely on the confrontation test? Well, if you don't have perimetry, of course, you can do a confrontation test, which is only a very rough test, but then I would more rely on my OCT, if you have one, and on the appearance of the optic nerve head in a dilated pupil situation. Pupillary reaction will be affected in optic neuritis. Yes, it is. One very early sign in optic neuritis is the afferent pupillary reaction. And most often MRI scans reveal something, but not always. So if we suspect optic neuritis, then the optic disc appearance can be quite normal. The patient has a decreased visual acuity. Macular scan, of course, should be normal in that case. And then afferent pupillary reaction deficit is a very sensitive sign and low-tech sign. When in glaucoma, evaluation should be concentrate more on nerve fibrillary ganglion cell, ELM, or all while making a diagnosis with OCT. So my favorite in early glaucoma is still the retinal nerve fiber layer. And for differential diagnosis, or when I'm not sure whether it's really something wrong with the nerve fiber layer or not in OCT, I take the ganglion cells. If the ganglion cells are completely normal, then I have my doubts whether the nerve fiber layer is really thinned. Does the red circle sign mean a neurological base? Well, the red circle sign is a hint towards it, but as I said, you have to check your B scans whether segmentation anatomy is okay, and perform, of course, then your visual field testing. Normal tension glaucoma and other optic neuropathies. Well, normal tension glaucoma does not have an elevated IOP, but the optic disc behaves the same way as all glaucomatous optic discs, and therefore it follows quite a different pattern than our other optic neuropathies. A disc at risk is a very small disc. These discs tend to have an anterior ischemic optic neuropathy. They may harbor Drusen, and therefore they have the risk for ischemic events. Another question, what if the visual field has spacely distributed visual field defects? What could be the problem? Well, when you have a diffuse field defects, I would first think of an optical problem like lens opacities. Can OCT detect anti-tuberculosis drug toxicity? Yeah, quite nicely by taking a measurement of the nerve fiber layer, and if you have the opportunity, the ganglion cell layer, and together with the central visual acuity, that's quite nice examination. When you have temporal retinal nerve fiber layer thinning, then I would next always look in the ganglion cell layer and the rim width and look whether it, and then of course look at the optic disc in order to find out a palea, temporal palea of the optic disc fitting to a neurological disease. Yes, ganglion cells may decrease with diabetic neuropathy, and here it is easier to differentiate from glaucoma because glaucoma has the vulnerability zones in the temporal superior and inferior part of the disc, but other optic neuropathies can be then a little bit tricky. Will blood sugar levels affect nerve fiber layer thickness and ganglion cell layer thickness in the long run? You will end up with high sugar levels in a diabetic retinopathy, leading at the end after edema to a thinning. High myopia, a very tricky topic because all our normative databases stop somewhere at -6 diopters, myopia, and at the moment we are taking part in a worldwide project with GMOPC supported by Heidelberg Engineering in order to extend the range of the normative database in myopia. Concerning the literature says that the ganglion cell layer may be a little bit more reliable than nerve fiber layer in diagnosing a myopic glaucoma patient, and OCTA would also be a little bit more reliable. But don't forget that when you do a macular scan, either for OCTA or ganglion cells, you have to have a very good image quality. And if you have a staphyloma on the posterior pole of your eye, then it is very difficult for a good segmentation. And then in my place, we end up again with imaging of the optic disc with a disc photograph, doing visual field measuring the IOP as we did 30 years ago. Well, the causes for optic disc swelling can be inflammatory, they can be ischemic, elevated cranial pressure, of course, and swelling to tumor compression. There are many different reasons for that. So let's look. We still got 2 minutes. When can we find OCT changes in retrobulbar neuritis? In the early phase, when there's no disc change, you might already find a very faint red circle sign. That's our experience in our place. But this red circle sign already correlates with a slight visual loss of central vision. And this sign is earlier in multiple sclerosis than nerve fiber layer thinning. And also OCTA changes are even more earlier, but for OCTA changes, you need a very good image and a very reliable machine to measure it. Well, the normative values for rim width are about in the mean 350 microns up and down. You will see in the literature where this normative database was published by Bourgogne and International Cooperation Group. If the patient has a normal IOP, how to interpret retinal nerve fiber layer thickness and loss of ganglion cells. So if the readings are normal, I would monitor the patient. The patient has some kind of risk, like positive family history. If the patient is pathologic, I would start with therapy. It's very individually different. In autosomal dominant optic disc atrophy in the beginning, as I know, they have no disc swelling. They start with the atrophy, and that's in contrast to Leber's optic neuropathy in the beginning. So I think the time so far is up. We had about 530 spectators and listeners. Thank you very much for your interest. Thank you for all the questions for discussion, and I hope you could get a few bits of new knowledge from this 45 minutes talk. It's 4:01. I would like to say goodbye to you and have a good morning, afternoon, or evening, wherever you are in the world. Thank you very much. Bye-bye.